everyone, welcome to another episode of EMS Connect. We're going to go ahead and get started. It is just 1 minute before 5 o'clock, so we're going to go ahead and just kind of get through some of our housekeeping items before we go ahead and get started here. So a couple of things as always. This is a live lecture, so it is rated E for everyone. So we're going to go ahead and talk about some BLS components as well as some ALS components. Sheri's done a really good job with this presentation of giving some great information to the BLS provider, how we're going to encounter or what we're going to encounter when it comes to lines, drains, and catheters, as well as some troubleshooting, some whoops moments, which I love. So got that taken care of, as well as for your advanced level providers, what can you do with those tubes? Can you access them in the field for medications and IV and so on? As always, this is our disclaimer. We may introduce new concepts in patient assessment and management, so please just make sure you follow your local protocols. Again, we have no way of knowing what your protocol allow or doesn't allow, so it's going to be up to you to make sure you check those local protocols and follow those. To communicate with us, info@emsconnect.org is our email. Our website, if you're not currently a member, www.emsconnect.org. You can join. You can take a look at our content and so on. As always, social media, Facebook, Twitter, Instagram, you can communicate with us for swag giveaways, conferences we're attending, and so on. Interacting with us tonight, I will be managing the computer side as I do most nights. So if you got a question, you're going to use that question box over on the right-hand side. So feel free to use that, and I will answer those questions. If I need to interrupt Sheri and get your question answered immediately, I will do so, but don't be alarmed if we use it to fill some time during a break or intermission or even at the end of the lecture. Also, the handout, the quick fact sheet is uploaded up there on the right-hand side under handouts. That's just going to be some general information taken away from this lecture as well. We will give away our Amazon $50 gift card tonight live at the end of the session, so make sure you stay logged on. We'll also post that on social media, and we will reach out to you and gain your information to be able to let you know that you've won. We're going to go ahead and get started with the meat and potatoes of this. As always, I am your host, Sean Pitts. I'm an advanced EMT, senior EMS evaluator here, or senior EMT instructor here in Spokane, Washington, and the head of education for EMS Connect. And I have the absolute pleasure of hosting Sheri. Sheri is a flight nurse with Life Flight Network. And what other letters do you got thrown on the end of your name?
Hello. Yeah, there's a few initials in there, but mostly critical care and emergency medicine, and currently with Life Flight for just over 5 years. And it's just my pleasure to be here with you and teach and educate and share knowledge with everyone about this incredible topic that we all encounter. And so this is going to be a good subject for today. Good learning experience.
Yeah, and Sheri, you might recognize her voice and face from our critical care series. We did a couple of those lectures last year, so we got you coming up with the rest of our critical care content, so you're able to break this down. So tonight we got lines and tubes and catheters. Oh my. I'm going to turn the computer over to you, and you can take it away.
Perfect. This topic is so important for all of us, especially because in this day and age, more and more patients are being sent home earlier in their stage of healing or post-surgery, post-events, and they're getting sent home with catheters and lines and tubes, and they're doing outpatient treatments and things along the lines of antibiotic treatments, infusions, blood transfusions, chemotherapy. And so what happens is these people are at home with these lines, and then we get called for a scene or a transport, and then we see these lines and we think, oh, we've never encountered this before. So this lecture is to encounter and to explain all of these different lines and tubes and what we can do and deal with them and manage them, and how we transport them, which ones we can use, which ones we shouldn't touch, and what do we do when we see them. And so that's the nitty gritty of it all. And so again, if you have any questions, feel free to pop them up, and then we'll get Sean going with those, and I can answer those questions for you. And so.
Perfect. Yeah. So we're going to start this one off of just kind of a general poll question of, if you were presented with a patient with a line, tube, or catheter right now on an ambulance call, fire call, how prepared would you feel? So just your general knowledge of where you currently sit when it comes to, understanding lines, tubes, and drains. I know me personally, depending on what it was, I feel like I could probably, I like number or B where I couldn't make them worse for sure, but um, we'll just kind of see where everyone sits. And then Sheri is going to get us plenty of experience as we kind of go through this. So
Yes.
we only got about 3% of people that say they are super prepared. So 66% say that they would make them not worse, and 31% is they want to get educated. So
Perfect. And that's kind of par for the course. I don't care who you are, how much experience you think you have. It happens to all of us. I don't care who you work with. You walk into an inner facility or you walk into a house and you're just blown away with what a patient has sticking out of them. And that's the game face moment. So
awesome. So sorry about that, but what is the best resource on scene to answer unknown questions that we have as providers for medical terminology? Most of us are probably going to agree that 100% is going to be our family
family
members.
members. Yeah.
Do you want to talk about that really quick?
Well, absolutely. There's no pride or ego in the game, and nobody knows how to use these catheters, these tubes, these lines better than the patient or their family members. I ask all the time, which line works? What do you do to make this work, or how do you use this? And especially in your pediatric population, nobody knows how to work the babes and nuggets tubes better than the mother or the father. And so I absolutely ask family about the best way to utilize any equipment, anything that the patient might have on them before I touch or do anything. And so it's the best way to instill confidence from the family and from the patient and to gain their trust too. So absolutely.
Perfect.
All right. So this is the basic slide that it's going to cover the topics that we're going to go over with today. And so we're going to be talking about your venous and arterial access, anything gastric, chest tubes, mediastinal tubes, any drains, wound drains that you come across, and they come with often little vacuum pumps that you might transport as well, urinary catheters, the different type of catheters, and your dialysis patients, which are a whole other scary ball of wax because you hear time and time again, don't touch those catheters. And so we're going to go over what you'll see, what you'll encounter, what you can touch, what you should avoid, what you should ask your medical director first, and just double check your policies and procedures. And if anything, this should trigger um, some curiosity in you to go through and look at your policies and procedures and to see what you can work with and what you should um, take education and classes for and kind of progress your skills and your abilities to be able to use this equipment. And so, but this is our general topics for each area of the patient. So you're transporting a patient that has their peripheral IV line pulled out. What is the best way to get that to stop bleeding?
Yeah, I love how aggressive you went. Either apply quick clot, apply a tourniquet. Are we
Tourniquet.
applying direct pressure, or are we just going to go with a plain old Band-Aid? I read this question. I was like, man, we're really going. We're going to
Tourniquet,
go
right?
at this one hard. We're just going to tourniquet her on the neck and just solve the
Exactly.
problem.
And so,
So give a few seconds here just to
yeah.
get people. Tragically, nobody decided they were going to go with apply a tourniquet uh, or quick clot, but most people said apply direct pressure. We did have a couple place of band-aids, obviously depending on probably
Yeah.
the amount of bleeding, but
Yep.
there's your results.
I love it. And so, yeah, direct pressure. So you think along the lines too that if IV line was pulled out, always think that if we're talking about something that we did in transport and we pulled something out, it probably wasn't done gently. And so there's going to be some underlying trauma with that pulling out. So direct pressure for that excess bleeding that we probably made happen. And think about also a lot of our patients are on blood thinners too. And so we've got that process that we have to think about as well, that we need direct pressure to make sure it stops and not encounter a whole other ball of wax with hemorrhaging going on. And so, which is going to be possible if we accidentally pull out some of our lines that we're going to talk about next. So venous and arterial access. This is going to encompass quite a bit. So I'm just going to go through just nice and steady, and we'll talk about the simplest, most basic one that most all of us in our line of practice do. We do the peripheral IV line. It's just our typical IV, peripheral hands, arms, ACs that we put the line in just to establish access where we can draw blood, give infusions. It's just the basics. And so again, the whoops, if we pull it out, just apply pressure and be aware of what medications you had infusing in that line, and if they can be paused for a moment while you restart another line, how quickly you need to get those restarted. Because some of us are transporting patients that have vasopressors going and they're completely dependent on these pressors, and we pull out that line and they're no longer getting that infusion. And so you've got to think immediately what will be the outcome of that whoops that has occurred. And so, and with everything that we're going to talk about, I want you to recognize the line, what's infusing, um, when something happens. I want you to be able to have excellent deductive reasoning. Why does the patient have this line? What do they have infusing? What correlating symptoms or illnesses they might have because they have this line? So big picture with everything, be able to take in the big picture. And that's kind of the game plan that we're going to go with all of this. So our good old peripheral IV lines. Um, then we have our peripherally inserted central catheter, and this is technically a central line that is inserted in the arm peripherally, goes through usually the brachial vein and up into the superior vena cava. And that is just right above the heart. And so that's why it's considered a central catheter, because the tubing of it, if you'll see in the image there, travels quite a long ways up into the superior vena cava. And so it goes to the central area of the body. So therefore, it's a central catheter. This is a long tube. And if this gets pulled out, there's quite a bit of trauma or damage to it. And that being said, you can also affect somebody's respiratory status and creating a pulmonary emboli if it gets pulled out too swiftly. It's secondary things that can occur if there is a dislodgement. And so to be mindful if somebody does start having respiratory distress along those lines, if this gets pulled out. But these are usually placed because a patient needs more long-term antibiotics or chemotherapy. It's a small bore catheter, so you don't do dialysis, do this, but you'll get the antibiotic infusions or chemotherapy. So when you go to your patients on a scene call or an interfacility transfer and you see this PICC line, you're going to know that they're getting some continuous or chronic treatments or infusions. And so, side note, this is called a PICC line, a PICC. And sometimes a peripherally inserted, a PIV, a peripherally inserted IV can be called a PIC, peripheral inserted catheter. So your simple short one that we do can sometimes be called a PIC. And so if your nurse or whoever you're talking to is giving you a report, clarify if it's a peripheral line or a central line, because you'll know which one's more permanent and which one's going to be having more long-term use. And this is a line that you'll see that's implanted that usually is purple. The tubing is oftentimes purple and it's secured with a clamping secured device. These can be used for infusions if you have a patient that needs a fluid bolus, things along those lines. This can be used. This can be safely used without any side effects or incident from that use. It's a good idea to see if you can get blood return before you use any kind of central line. And so there's usually an attempt to pull back and see if you can get a blood return. And that way you can also remove any risk of getting a thrombus. If you're removing any clots from the tip of that catheter, you're able to pull back that when you get blood return. Now that being said, oftentimes the PICC lines, the peripheral inserted central catheters, are the hardest to get blood return on because they're so long. And more times than I can count, I've had a patient that I've tried to get a blood return on their PICC line, and they just say, oh, that it doesn't return blood, but it takes. And so you kind of have to weigh that on is, should we attempt to use it and trust this patient, or should we avoid using it? So I guess it depends on how good their other vascular access is. Maybe you should just shoot right for a different line. But if they don't have anything else, it's one of those where provider judgment and your on-call medical advisor, it's definitely usable. So then we have central venous catheters, and these are placed more so in the chest, and they come with different names, a wide variety of names. You've got your Hickman and your Groshong. There's several that are used in more the pediatric population, but you'll see your Hickman catheter more so with your patients at home. They'll get sent home with this catheter quite often because this is a more permanent placed catheter. It's called a tunneled catheter, which has some antibiotic and some bacterial resistant capabilities to it. And so it can be staying in for a long time in the patient's chest and be used for long-term infusions. And so that one's going to be a common chest catheter that you'll see, a central catheter that you'll see. And those are just very similar to the PICC line in the sense that they're usable. They are absolutely usable in the need of infusions or fluid boluses, administering medications. They're usually multi lumen. They have several different tips on them that you can, you don't put your needle in it, you screw the hub on, and you're able to administer medications that way. And that being said, side note, most all of these have the screw-on hub, and they go directly from that hub into the patient's, towards the patient's heart. So it's not a bad idea if we're even moving swiftly to try to clean the hub before we give any medicine or fluid boluses, just so we don't introduce any bacteria or any infection risk to the patient, because they're probably already immunocompromised, which is why they have that line. So we won't help them get sicker with any infection. So if that's possible, then we'll do that. But so you'll hear the different names, the different types of central venous catheters, the tunneled, the non-tunneled. Usually in the ED or in a traumatic situation, you'll have the non-tunneled catheters, which are and we've probably all seen them, the catheters that are in the patient's IJ. Usually it's a bloody mess with a Tegaderm over it that's really just kind of slapped on there and used in a critical fast situation in the ED. And those are usually only used while the patient's in the hospital. But if they're sent home and if we're at somebody's home, we'll often see the tunneled that's in the patient's chest.
Yeah, and I'll tell you, I mean, I don't have a lot of experience with this transporting patients, but you're mentioning if we're administering any medications through that to make sure we're not, causing any infection, but
Yeah.
also be aware of the populations that maybe their hygiene's not nearly as great as it should be. So the chances of infection that they already have.
Right.
Now, that's the reason we're being called, is for the signs and symptoms of the infection, but it
Right.
came from,
Right.
the improper use of this device. And question, so what do you do if the central catheter gets pulled out or dislodged? Is it pretty much just the same treatment as the PIV line, just good direct pressure and
Yep, absolutely.
obviously transport?
Yeah, don't let it delay your transport. Again, any one of the central catheters, so your PICC line, your PICC line, or your central venous catheter, anytime those get pulled out, due to the length of them and the placement of them, sometimes an emboli can occur in travel. And so you'll want to monitor respiratory status, how the patient's breathing. It's not a common thing, but it can definitely happen. And that is one of the side effects of pulling out those longer central catheters. So in the whoops moment, if it gets pulled out, and it's an absolute possibility that it gets pulled on, it might not get pulled all the way out because they're quite long, but if it does get pulled in a very tense manner, that it could cause a little bit of damage and possible respiratory effects. Some of these are sutured in, and you would have to do a valiant effort to get it pulled out. But then again, when you say that you've never seen it happen, that's when you're going to see it happen. And so lots of pressure on that site, and then just look for a peripheral line. And again, what was infusing? Did they have any medications? Did they have anything infusing on your inner facility? Was there a vasoactive drug going on that. Because 9 times out of 10, people that are patients that are in the ICU are going to have all their vasoactive drugs, all their critical care drugs transition to a central line. They won't have a peripheral line. And so if you are doing an interfacility, they've got drugs that are keeping them alive. So if you can quickly, swiftly move to a peripheral line and start a peripheral line and do that, that is a priority.
Yeah, and I love this. I mean, the slides are kind of wordy, but we left this way on purpose because there's a ton of information that's available. And the important stuff is the what and the where. We should know what these are for. The good news is that's the kind of stuff that you can, on your side time, you can
Right.
Google and find out where. But the quick fact sheet, and you're doing a great job of really drawing attention to the whoops, because
Yeah.
that's the stuff that's going to totally catch us off guard.
Right.
Is that gets pulled out. And like you're saying, it might take a valiant effort to get this pulled, but we've all probably moved a patient in a hurry. We don't realize something gets hooked on a stretcher, something gets hooked on a bed, something gets
Right.
pulled that shouldn't. So these are definitely the possibilities that these become,
Yeah. An IV pole gets dropped, something along
exactly.
those lines that has some weight to it, and then if it falls, that it can pull on that, and then damage can be done. And it doesn't. I mean, we've all been there. We've all tried to keep our lines straight, organized, everything moving smoothly and swiftly, and it's Murphy's law. It's going to happen. Something will happen. But
For sure.
yep. So our Caths, these are an implanted central venous catheter. And I'm sure many of us have seen the round disc that's implanted below, surgically implanted below patient's chest, and you can see the um, the round dial and the hub that's on that. And that is accessed with a special Huber needle that has a 90-degree bend to it. And some EMS providers are able to access these. They have them in the ambulance to be able to access these. And so they're very distinct. You can see exactly where you need to insert the needle. There's usually, if you palpate the chest and feel that rim, that circular rim, you're going to see or feel 3 little bumps, and you just need to aim the needle between those 3 little bumps. And often for our transports, they're already going to be accessed with that 90-degree bend needle, that special needle, and those are wonderful to use for any fluid boluses, any medications, anything that you need. It is just basically another central line, but it's surgically implanted because somebody's going to permanently need, or at least for years, need chemotherapy, different antibiotic treatments, if they have need chronic blood transfusions, things along those lines. That this is something that's put in because, one, if you have a chest central line that's got the ports that sticks out and it's not surgically implanted, you can't function with a normal daily routine or life. It's difficult to shower, it's difficult to have normal activities. But people that have had them surgically implanted, you can swim, you can do showering, and you can do normal daily activities, and they're not impeded by having the actual catheter sticking out of your chest and under the skin. And so the catheter is a 90-degree bend, and it's implanted in that silicone self-sealing hub, which is why you can keep repoking it and pulling it out, because it's got this excellent silicone hub on it that is also why you need a special needle to use for this catheter, for this access device. And so this is really tough to pull out, but again, it could happen.
When
You
you
could
say
give
you
it
can't, it will.
exactly when you say you can't, it will. And so just be mindful of if what's infusing in that device, and if you need to restart peripherally. And as a side note, a lot of people have these surgically implanted devices or these central catheters because they're not easy IV starts. So that being said, what do we do next? What's our next line? An IO. I mean, if somebody's crumping right there in front of you and you don't have ability to access this, it's not in your scope of practice, it got pulled out and there's no place to find an IV site, stick an IO in them. It's just, if they're going to need it, they're going to need it. And so just be proactive and keep moving forward, and then don't get hung up by the little process of it getting pulled out. It's a hiccup. Move forward, keep moving forward, and that's progressing forward with your patient. And so we have the venous access, a central venous access, and then we have our art lines. And so with our arterial lines, the access point is arterial based. And usually the most common sites are going to be in the wrist or in the groin, so radial or femoral. Those are your two biggest access points that are most commonly used. And these, the patient won't go home with them. This would be your interfacility transport. And so let's say you show up and you are at the patient's bedside and you're getting all the lines moved over and you see this arterial line. You're going to see the patient usually has a restrictive device like a wrist splint on the wrist because they should not bend or move this site to pinch it off or close it off because it's a continually um, pressurized line. And the terminology and the phrasing, and I know that photo can be overwhelming, that all the lines and what's involved with it, but there's really just a line from a pressure bag to the art line and then a line to the monitor, because your arterial line, one of the benefits of it is you can get continual blood pressures. It is fantastic. It is nonstop blood pressure readings. And so you don't need a peripheral blood pressure cuff on the patient because the arterial line is continually able to read the pressures in that artery and seeing what their continual blood pressures are. And so they're in the scope of some EMS practitioners, you're able to have the monitor cables that plug in, and then you plug it into the art line, and you do what's called a zeroing of the art line, and then you can read these. And so this is something that if anybody wants to talk about putting in their scope of practice or learning more, this could be a whole nother area of discussion. It's a whole nother ball of wax. But what I want you to take from this is that it's in a patient's artery. What happens when we pull out an arterial line?
A lot of blood.
A lot of blood. So out of all of the lines that you might pull out, that might be, oh, whoops, is the art line is going to be a bleeder. And so this is definitely one where if you unintentionally pull it out and you did have it on a monitor, it was reading on a monitor, you probably don't have the continuous blood pressure. So you'll have to do a peripheral blood pressure cuff, which is easy. Just keep moving forward, slap that blood pressure cuff on, go with it, and then definitely pressure to that art line side, especially if it's a femoral line. It's going to be a bleeder. And don't try to reinsert the art line or any of these lines. Don't try to shove it back in. Once it's come out, just leave it as is. It's good and it happens, and keep moving forward. Progression with patient care. So.
And documentation.
And documentation. Yep, exactly.
Even though it's going to make you look like an idiot.
Sean pulled it out.
Yeah, for sure. For sure. Way to blame that on me. I like it.
And then we've got our gastric tubes. And so this is an area that we don't realize um, how actually wonderful it is to be able to use these. And I wish we could use them a little more in the field, because the nasal gastric tube and the oral gastric tube are often used for just rapid, easy decompression of the abdomen, the stomach, because you arrive to a code and this patient's been being bagged for 40 minutes. And amazingly enough, you get ROSC back, and now they have horrible cardiac output there because their heart just can't perfuse very well. And you notice that your normally thin patient looks like they're 9 months pregnant and their belly is just distended and firm. And there's not much room for the heart to pump and to perfuse because that abdomen is so distended. Well, how'd that abdomen get distended? All that bagging, the bagging of the air, naturally goes down the esophagus into the stomach. And the fastest way to get that decompressed and get that air out of there is to be able to put down an OG tube, especially if you've intubated, be able to slide that down. And so having this in some of the provider scope of practice is a wonderful tool, because you can rapidly decompress and just push on their stomach, and it just goes flat and the air comes out, and now poof, there's more room for the lungs to fill up, there's more room for the heart to pump, perfusion is better. It's just that concept of deductive reasoning and taking in the big picture of what you're doing and the care you're providing and the side effects of the care you're providing and the resolutions that you can do to fix it. or even noting to the facility when you drop off your patient that, hey, we did bag them for 40 minutes and I noticed their stomach's distended, so maybe they can pop in a tube, a nasal gastric tube or an oral gastric tube pretty quick and get that decompression going. These are temporary tubes that are placed, and so they're not something permanent that somebody would normally go home with. So it's more of a temporary measure for decompression or um, for feedings. If somebody's having a little bit of anorexia or difficulty eating, then they'll be able to put this in and temporarily use it. So, side note with the NG tube, you'll never put anything into somebody's nose if they've had a facial trauma. So just side note, that's a little disclaimer. We all know that. We all remember that. Nothing nasal on a facial trauma. And so aim for the oral. If you do have this in your scope of practice, or if you're able to put this in your scope of practice, oral once they're intubated would be the best way to go too. And so um, and you don't even need to hook it to suction. It's something that you can cap off once you've got the air decompressed, or follow the facilities what they've been doing. You can hook it up to low suction to keep the gastric um, decompression going. And this is often the rapid, quick way if somebody has a twist in their bowel or a kink in their bowel. Oftentimes in the hospital, they'll put somebody on food restriction, nothing by mouth, they can't eat, pop in an NG tube, put it on low suction, and it decompresses that gastric lining, and the twist and the kink come out, and problem solved. And um, so sometimes if you're doing an interfacility transport and maybe it's a patient going to a nursing home, you might see the NG or the OG tube um, in place for that as well. So these don't have a ball on the end of them. They don't have anything that keeps them in place. The tape that somebody has put on their nose or by their mouth is what's keeping it in place. It's specifically measured in centimeters on how far it goes down into their stomach. So this can easily be pulled out. But it's fairly traumaless. It's once it's pulled out, the patient will probably thank you. And so, because it's definitely not fun to have it in your nose, but you'll need to make sure to document and to notify the provider that it has been pulled out, so it can be reinserted.
Is
So
it your routine practice? Do you note where it is on that centimeter line at the start of your transport, and then have a mental note of like at the end of transport, hey doc, I did notice that,
right.
do you do something like that, or is that just
That
me?
is an excellent practice, excellent, because it's also it's a CYA. I mean, it's totally one of those things where, oh, it was working when we gave the patient into your care, and now it's not working. And then you can document, this is where it was when I got it, this is where it was when I handed off. And so it's just one of those where it's style points. That, and if you want to look good on your charting, style points, definitely put that in, because you can also document that there was nothing in between care that in the handoff where there would have been any reason or rationale why it would not be working. So
And I like
yeah.
these because your whoops on both of these is really straightforward. If they come out, no big deal.
Yep.
Just don't use them,
Yep.
and we're
That
just gonna
simple.
we're just
Yep.
gonna move on.
It's not life or death. This
Yeah,
one
I
is,
like
yeah,
it.
not life or death. And gastric tubes, this is always scary when you come across a patient that has something sticking out of their abdomen. And again, this is not a life-threatening or scary situation per se. It's, if it gets pulled out, it's not going to be something that's going to affect them greatly, other than being slightly painful. So your gastronomy tube is inserted into the stomach, and the judostomy tube is inserted in the small intestine. So it's just basically where the tube is in the patient. And again, we might never encounter these, but it's sure style points to be familiar with the words, the terminology, or this patient had a peg tube, and so you can think in your head, oh, okay, so why did they have a peg tube? Were they not able to take anything by mouth? Were they not able to swallow? Or they have one now because they can no longer take anything by mouth. So that's what I want you to get out of. If you see this tube coming out of your patient's stomach, start thinking, be that person that can deductive reason, oh, I probably shouldn't give him any pills to swallow. because they're probably not able to swallow. So you're going to note that if you're coming across your cardiac patient that you're going to want to have them swallow an aspirin, and it's just nope. Everything has to be either sublingual, dissolvable tablets, IM, IV. Don't try to get them to swallow anything. And so because you're that awesome of a provider, you can tell that we've got this, so I shouldn't do this. And so these do have a small balloon that is inserted, that is inflated in the small intestine or in the stomach. And so if it does get pulled on or pulled out, there will be some abdominal wall trauma because that balloon will widen up that little stoma, that little fistula area. And so there won't necessarily be any bleeding because usually that area in the abdominal wall is really well formed, and so it's just one of those where the provider will need to reinsert the tube and maybe do the next size up, the next larger balloon size, while that area heals. But again, it's kind of whoops, and it's a little bit of a pain for the patient, and you'll probably have some gastric drainage with it, so you want to apply a dressing on it so that the gastric draining isn't oozing everywhere. But otherwise, it's just make sure there's no feeding that's being administered and stop anything that might be flowing in, and otherwise just kind of contain with the dressing.
It's nice because I think we're seeing more and more protocols that are allowing EMT, BLS providers to transport patients with these devices
Yeah.
already in.
Yep.
Because you're not really doing a whole lot with them. Kids that go home with
Yes.
feeding tubes
Yep.
one of the experience I had was they were twins, and one kid pulled on the other kid's,
Yes.
G tube. So
Yes. Yep.
it became dislodged, and,
Yep.
obviously concern from parents, but that's a BLS transport.
Yep.
There's nothing really life-threatening going on
No.
that we need to be terribly concerned about.
Exactly.
So good information of the whoops is awesome of,
Yeah.
okay, so what do we do when this becomes dislodged?
Right.
Most of the treatment's pretty straightforward.
Right. And just being familiar with the tubes, the lines, what you're seeing, and the terminology and the words. And so when somebody says, central venous catheter or PICC line or things along those natures, you're like, okay, and you can visualize and think deductive reasoning, why they might have it, what's going on, and what could I do if something happens, something goes wrong.
All right, so here's the next one. And this one, there is a restriction on how many words can be on the poll. So we're going to read the question and then I'll launch the poll. But you're packaging a patient for an interfacility transport. You see they have a chest tube drainage unit. What is important to remember when transferring this patient? And this was just kind of to see who had kind of some experience. But is it A, clamp the tubing and secure the drainage unit hanging on an IV pole? B, do not clamp any tubing and keep the drainage unit above the axillary line. Or C, do not clamp any tubing and keep the drainage unit lower than the patient's chest. So again, we have basically, clamp the tubing and secure it to the IV pole, or don't clamp anything and keep the drainage unit above, or don't clamp any tubing and keep the drainage unit below. So we're gonna let this one go for a minute and just kind of see where everyone's at. And then Sheri is going to educate all of us that get this wrong on what is the right answer. All right, so here's what we got. We got 5% of people said clamp the tubing and secure the drainage unit hanging from the IV pole. 7 want do not clamp any tubing and keep the drainage unit above. And then we got 88% with do not clamp any tubing and keep the drainage unit lower. So obviously the right answer is do not clamp any tubing. And I say obviously, I really didn't know this, but clearly the answer is do not clamp any tubing and keep the drainage unit lower than the patient's chest.
It's obvious now that we have it in red.
There you go. Absolutely. That's the obvious part, is it's in red. So why don't you talk about those chest tubes?
So chest tubes, and even to this day, even being very familiar with them, I'll walk into an interfacility and I'll see a chest tube and I go, ugh. It's definitely, and adds another element to transporting the patient, and definitely a tube that you don't want to pull out because it could have pretty swift side effects. And and having that catheter, which it has to be transported a certain way, which is below the chest, below the insertion site, because a lot of times it is to gravity that you're transporting the patient's the chest tube. And so if we start off with a slide here, we've got your chest tube or thoracic catheter. Sometimes you'll go into a facility and they're really fancy and they'll say he has a thoracic catheter. And so it's a catheter that has kind of holes in one end of the tube, and it sticks out of the side of the chest, usually on the lateral side of the chest, and it's hooked to um, a unit, a chest drainage unit. And it's really important that when you walk in and you see this patient and you're doing just a quick assessment, you're making sure that their respiratory status is good, that all the little holes that are on the side of the tube that's up near the patient are actually inserted. I've gone into some of their facilities and some of those tubes are not all the way in, which just makes your chest tube kind of a moot point. It's not really working that great with good suction. And so you're just reassessing and checking for respiratory status. And so it's usually secured very well, sutured in, taped in. You'll see all manners of creativity with tape and dressings that are going to be over that tube because they don't want it to come out. And then again, it's going to be hanging down to the drainage unit. And the next slide, they'll have a picture of a drainage unit. We'll talk a little bit more about that. But so that's coming out of the patient's chest, out of usually the side of the chest. And again, it's monitoring for respiratory distress. If it gets pulled out, it's an open chest wound, and so you can start monitoring and preparing for interventions that we would see with any open chest wound. And so three-sided occlusive dressings are still the practice, but there is some studies that I know the military are doing and that some hospitals are actually going with, where they're just fully occluding that hole and then needle decompressing if any tension physiology occurs. And so there's a couple different practices and studies and research that are being done. I think the trend is still the typical good old open chest wound concept, where you do a three-sided dressing and then just go whatever your medical director has trained you with. And so, but if the tube's dislodged, monitor their respiratory status, and that's just it. And if somebody's had the chest tube in for a while and it's just hanging to gravity and their pneumo has actually resolved, sometimes even dislodging the chest tube and having that dressing on there, you'll not have any distress. The patient won't change status at all because their pneumo has resolved and it's become a non-issue respiratory factor. It's gonna hurt. I think they'll probably earn a pain shot of some sort with this because there was probably some sutures in there and a lot of tape, but it's not it's not an impossible factor with all of this tubing and whatnot draped from the patient to have it get hooked up into something or a wheel on the bed. Yeah, not uncommon. And so that's the long chest tube thoracic catheter portion. Some patients have what's called a flutter valve. It's a small valve that is attached to the end of a catheter that's protruding from the chest. Usually it's in the posterior area of the chest, and it's for smaller pneumos. And a lot of patients go home with these. So you might encounter if, let's say that you get called to a scene call in somebody's house and they got discharged earlier this afternoon with a flutter valve, and now they're having some respiratory distress and some concerns with their ventilatory status. And so you might put two and two together that the flutter valve didn't resolve the pneumo fully. You might have to needle decompress to help out again. A quick assessment of the flutter valve, and you might realize that the end, it's a one-way valve. So air can come out, but it cannot come back in. But you need air to keep coming out. And so what if the patient is snuggled in with blankets and is put on their sweatshirts and they've covered that end of that flutter valve and there's no way that air can be expelled out of the end of that. And so knowing the equipment, knowing what you're looking at, that, oh, that's a flutter valve or brand name Heimlich valve, and knowing what the patient shouldn't do with it, what you shouldn't do with it, and covering that end up. And knowing that it's for, if you see that, like the images there, that is for a pneumo, that is for a small pneumo, that's being resolved at home. And usually those are put in those tall, skinny kids that get pneumos. You know, you hear tall, skinny kids, males usually can often get a small pneumo, and that usually is the resolution treatment for those guys. So again, if it gets pulled out, just monitor for ventilatory status and any difficulties with breathing.
So the nice thing, right, is to make this as simple as you possibly can. This, I mean, where was the device?
Right.
And so if it's in the chest cavity and it gets pulled out, the answer is seal the chest. If it's in an
Right.
artery, and it gets pulled out, like it's an arterial bleed.
Yep.
Like the simplicity of this, we
Make
don't need
it
to
basic.
overcomplicate it, right?
Exactly.
And then obviously with any sort of respiratory distress, respiratory changes, I mean, a bag valve mask is probably going to end up being an option at some point if they're respiratory failure, but no positive pressure ventilation with like CPAP or something along those lines, correct?
Right, especially because they're more than likely getting a tension physiology or something along those lines is occurring where their lungs are not capable of that pressure quite yet. And there is the possibility that they could have what looks like a chest tube catheter coming out the middle of their chest. And I can assure you that the first time I saw that, I was like, what? Because it's just the chest tube and it's coming out right near where their heart is at. And this is often placed, not often, but can be placed after cardiac surgery to prevent tamponade. And so the same concept where there is a catheter tubing that's coming from the middle of the chest to a drainage unit. So it's one of those things where you might show up and you might have 3 drainage units that you're doing on a transport, and one is for maybe one for each lung, a chest drainage system for each lung, and then one for that cardiac cavity to drain blood if there's any concerns with the tamponade. And so don't be shocked one day if you see a tube sticking out of somebody in the middle of their chest. And if that gets dislodged, then there's a potential for bleeding, and so there'll be pressure, and the potential that if there was a concern of blood building up around that cardiac cavity, that it might still build up and cause a tamponade. But since you have an open drainage port now, that just keep pressure on it and notify the receiving doctor that what has occurred. But yeah, monitor for cardiac output is going to be the big one with that. But so the scary part of all of it is, what do I do with that drainage system? And you're going to see and hear terminology of like a wet system or a dry system, an oasis system, and it's basically 3 chambers all in one box. And one of them's a collection chamber, and one of them's the water seal, and one of them's the suction, um, the level of suction that you'll put on that chamber. So usually it's all squared away and set up, and the job is simply to take as is. These do not have to be hooked up to a wall suction. It's just if the patient has a large pneumo or needing an additional pressure assistance to keep their lung inflated and assist with that negative pressure buildup in the lung area. And so bottom line, the words with that is, it might not be hooked up to anything. It might just be called water seal. And that's a terminology, a phrase that if somebody says they've got this chest drainage system that's on water seal, oh, easy. That means it's not hooked up to anything. That means you just take that chest tube system, you make sure that you keep it lower than the patient's chest. So you can hang it on the stretcher. You can hang it down lower as long as that unit's lower than the insertion site, and just roll with it. It's just that easy. Monitor that you don't get it pulled out, that you have it unclamped. So don't clamp the chest tube. You want to leave it open to that air pressure, that negative air pressure, and it's doing its thing. And so just don't clamp it, don't elevate it, just simply hang it off the side of your stretcher and roll with it, and be mindful of that little box, and don't pull it out.
Don't drop it.
Don't drop it.
All right, so we've got to our intermission just a little bit earlier than we thought, which means we're right on track to be done a little bit early, which is always awesome. So I'm going to give Sheri a chance just to kind of take a break and hang out for just a second as I go through just a couple of our typical intermission things. So if you want to get something to drink, refill, something along those lines, you're more than welcome to do so. And the thing we announced, I think back in February, or maybe even January, that we now have the ability for agency admins to upload their own content. So there's a tutorial video uploaded for that if you're troubleshooting that, but super easy. Upload YouTube videos, Vimeo videos for your agency, assign them just to your agency, and you can write your own test questions, and it will act as a course just like ours do under the courses tab with EMS Connect. So that's awesome. I'm going to turn this back over to Sheri, and we're going to continue with wound drains as we get close to the end. So back to you.
Awesome. Thank you. Thank you. So again, if there's any questions, there's no such thing as a dumb question. If there's anything that's probably dumb that has occurred with any patient care, I've probably already done it, and and I'm speaking from experience when I explain something. And so I have really no ego or pride because I've probably done it if it's been a something that you shouldn't be doing. so so with the wound drains, these are also, they kind of spike a little nerves when you see these because there's little tubings that come out of the patient's body and they're filling with this bloody drainage. And you come across these when you get called onto a scene or to somebody's home and to transport them, and you think, oh my gosh, this little ball or this little tube is weeping blood or it's full of blood and they're hemorrhaging. And so the thing with the what's called a JP drain is that it's a small tube that's inserted surgically, post-surgical um, procedure, inserted into that surgical wound, and it drains out from that surgical wound, and it keeps any buildup from any bacteria and bacterial infused fluid from staying in that wound. So it's allowing free drainage from that wound site. A lot of times, post mastectomy, post-cancer treatments, they're placed bilaterally on the chest wall of women that have had their breasts removed. And so that's a very common time that you'll see them if you've encountered them. And so, so you think along the lines of, yes, it's okay that there is some bloody tinged thicker drainage coming out of that into that bulb and out of that tubing and is being collected, because that's the job of that drain, is to keep it from staying in the patient, keep them from building up a bacteria source. And so don't be alarmed when you see that. And so it might be possible though that be that deductive reasoner, that if you get called to a scene and this patient has had this done, know that they are really soon post-surgical patient. So start thinking about what you might encounter with somebody that's just had surgery. Do they have any complications infection-wise? Are they getting septic? So start noting that. Be that deductive reasoner. Be that medical person that knows there's something more going on because they've just had surgery. And so don't let the drains fool you or make you stutter. Think bigger. Think that do they have any respiratory complications because they probably just got extubated and discharged, because we all know in the medical field how quickly people are getting discharged home after a procedure. It's just somebody's just had a massive surgery and 2 days later they're home. And I think we all encounter that as pre-hospital providers because we get called to these homes more and more. So that's why we see more of these catheters and more of these wound drains and more Heimlich valves and things along those lines, because we get called to these homes because these people are quickly released from the hospital now. And so be comfortable with these things that you come across, like these drains. And the Penrose drain looks even more medieval because it's a rubber tube that is sutured under the
Just
skin.
looks like surgical tubing cut in half.
Whoops, they forgot the surgical
Yeah.
tubing in the patient. Like, no, it's actually a free drain that's draining into some dressing that is just kind of a medieval way of keeping that, making sure that wound weeps a little bit to keep that bacterial lining from being built up. And so don't see that and think, ugh, and pull it out. Just leave it in place and transport as is. And so because it has a job, it's doing its job. It's draining any bacteria and wound. But again, the whole process with this is knowing that my patient's just had surgery or has been discharged post surgery. What else? What's the bigger picture? What could be going on? And so, and with again any tubing in line, it could be pulled out, and it's okay. It's been sutured or stitched in, and if it gets pulled out again, it's some integumentary concerns, some skin trauma, but it won't impede transport. Don't stop transport for this. They can. There's going to be a bigger issue going on than the drain getting pulled out as to why your patient needs to go back to the hospital. Something bigger is probably going on, and they can reinsert the drain once you get to the hospital. So,
And I think it's important, especially, I mean, I feel like EMTs again, our BLS providers get a little overwhelmed with this stuff, but great questions is I know with these JP drains, there's usually some sort of tracking of how much fluid.
mhm,
So if we're transporting those patients, making sure we're asking those questions of how much fluid has been drained, because the hospital is
right,
going to be asking us those questions, and then we want to make sure we have the answers. So
right,
usually there's some sort of log of family has been draining those and tracking how much fluid, because I know there's a correct amount and how much, and it's supposed to decrease over time as
right.
so those are definitely questions to ask. Again, family is going to be probably your best advocate. You can use online medical direction if you're truly in the dark and
Yeah,
family has no idea, but most likely patients and their families are going to have a pretty darn good idea of what
exactly.
the expectation is well, is that color normal?
Right.
And don't get misled under whoops where it says JP drain, where you might have, and I'll let you pronounce that word, drainage or weeping. That's not a bad thing, right? Like that drainage and weeping is a normal thing.
Normal thing.
That doesn't mean it's become dislodged. So if for some reason there is a dislodgement,
Right.
the fact that you have fluid is not meaning it's becoming dislodged.
Right,
So
exactly. And so, and it may be that that drainage now is coming out just of the actual wound site where the tubing was. It may just be weeping out of the actual hole that no longer has the tubing in place. And that's okay. Just addressing over that, and that is just fine. And even style points of how much was in when you started your transport. Like, let's say you have a long transport, you get this hour-long transport ground, and it has this much in it, and you can just even show on the bulb because it's got these little striation lines on it. It was this much when we left, and now it's this much, and it wasn't this red when we started, and now it's very bloody. And so things along those lines, just giving the receiving doctor an idea of it's now draining quite a bit more and it's more bloody. So style points on documenting what it looked like when you got the patient and the difference when you drop off. And so doing that with any time that you transport, being able to compare, this is what it looked like when I got the patient, this is what it looks like now, is going to just up your your credentials and your cred, your street cred when you get to the hospital.
I like it.
And wound drains. This is something that's quite often seen, especially with nursing home patients. If you're transporting from nursing homes and they're getting chronic treatment for pretty severe wounds, they have hemovac or a wound vacuum in place. And so it's this dark colored foam that's squished basically down into the large open wound. And in the middle of it, there's a little vacuum tube that's put down right up against the wound, and it's hooked to a little vacuum, and it just creates this suction seal, and it vacuums out again that bacteria. You can kind of see a theme going with any of our wound patients. You see a theme of the any bacterial laden fluids getting drawn out. And so you might be transporting a patient that's hooked to a little vacuum, and that's totally fine. It's one of those things you can just put it right between their legs on the stretcher, and they're tiny, and just go. And it's the sponge material is sealed with kind of a one-sided, like very large Tegaderm dressing that's very, very stout and solid and secure. It would take quite a bit to pull it out, but again, if you pull out the tubing and pull out the vacuum, it usually a little bit of air will get into that wound site and inflate the sponge a little bit, but otherwise it's no harm, no foul. Don't let it delay patient care. Don't let it delay treatment. And so just grab and go and take off and apply a dressing, and don't let it delay what you're going to do for the patient. Catheters, yay. And again, these are often seen right after post-surgical patients or in our elderly population that need the urinary monitoring. And so remember that your catheter is inserted in the urethra, and at the tip of the urethra, there's a large balloon that's inflated with air. And so if that gets pulled out, there will be pain and urethral damage. It's not going to be pleasant for anybody involved because it definitely will be painful. And so be mindful if that's getting tugged or pulled on, and be aware of where your catheter, your urinary bag is hanging. There's been a few times where you'll see it dragging on the floor because it fell off the stretcher.
That's where I was going to go. Is this seems
Exactly.
to be
Yep.
the one that
Yep.
falls off the wheelchair when you move them to the stretcher,
Yep.
you kind of forgot it was
Yep.
attached.
Yeah,
We're sorry.
exactly.
Yeah.
Yep. So you don't want to do any more trauma that could possibly occur. So be mindful of that balloon that's inflated in their bladder with the damage, and that could occur with that. And then there's the PureWick catheters that we're seeing now. They've they are going away from inserting Foley catheters in our female population because of the UTI risk. And so these really awesome PureWick catheters are um, just this little device that gets inserted that's hooked to suction, and it's non-invasive, and it collects the urine if there's any weepage or moisture. And so, and I can honestly tell you the first time that I encountered a patient with one of those, I thought, I'm not sure what that is. And then I realized I think I've seen this on TV before I'd even had any training, because a lot of times they're using it as home health care. And so it seems to be the way they're going with hospitals now to reduce UTIs. And so if you see this little device that's hooked to suction, that's pulling the urine out in a non-invasive manner in our female population, then just know that you can cap it off and not have it to suction, but you will have urinary drainage because of that. It's because there's nothing collecting the urine, or you can opt to leave it hooked up to suction. If that gets pulled out, the Pureit catheter, it's just going to be tugging on the patient's skin and as it's getting pulled out, but there's no damage that's done, not like the Foley catheters. So. And then I think I forgot to mention the suprapubic catheters too, just real quick. I just want to mention those actually are in the patient's abdomen. So it's kind of like the gastric tubes where there's a balloon in the bladder, just like a balloon in the stomach in the gastric tubes. These are in the bladder, and usually there's a good um, hole formed into the bladder, so it's drained via gravity often. And if that gets pulled out, kind of same thing with the gastric tubes, it's going to hurt. There's a little balloon at the end of it, but oftentimes it can be reinserted at the hospital. So yeah. Dialysis patients, oh my goodness, this is a whole other ball of wax for our treatment and care, because I've never encountered a, a a line, a tube, an area of the body that is so protected than our nephrology doctors that hover over how diligent we can't touch them and we can't insert anything in them. And I think it's because it takes a lot to get the patient set up for dialysis. It takes a lot to get a fistula going. It takes a lot to get that process going, and that's often why anything regarding dialysis access, usually EMS providers can only access it during arrest or peri-arrest. I mean, they want the patient basically to be dying before we can even access the dialysis catheters. And so um, what you'll see with your dialysis patients, and this is also the putting two and two together moment, where you get called to a scene call for a patient that's having some chest pain and some palpitations, and you walk in and you note that this patient has this fantastic, huge bulging vein in their arm, and it's just like this awesome looking, what looks like an AC vein, and you're just like, wow, this is awesome. Um, what should immediately come to your mind is that, oh, that's a fistula. That is not an IV site. That is created surgically, and it's under a large deal of pressure. There's a lot of pressure up against that. So our IV catheters, it would just being able to infuse anything in that is near impossible because the pressure to go out is so forceful. And it's also should trigger in your mind, they're a dialysis patient. They have this fistula. Um, the deductive reasoning of that is that oftentimes our dialysis patients don't have great electrolyte balance, and so go down that path where they probably have peaked T waves, and this goes into our more advanced and our paramedic level, but deductive reason, and even if you're packaging and transporting for a basic transport, know that there could be more going on underlying that could occur that is bigger than we're anticipating too. So put two and two together. But your AV fistula is a surgical connection of an artery and a vein that creates that big, beautiful bulging vein. AV graft is a synthetic tube that connects an artery and a vein that is just about the exact same as a fistula. And what this does is it gives the dialysis nurse great access, easy access every single time. Because I have never encountered, and I can use the word never, not very often, but a dialysis patient that has good veins. It's just not a common thing at all. And so they need this fistula or this graft to be able to access continuously for dialysis. And so dialysis is a whole nother ball of wax where that blood gets removed and dialyzed and cleaned and then reinserted. And that's what's happening in that fistula all in one site. It's coming out to the machine and going back in, coming out, high flow, high volume, lots of pressure. And then some of these patients do get a central venous catheter. So you're going to look at their chest and you're going to go, oh, this is a central venous catheter. The difference is, and what's going to alert your spidey senses, is this catheter is going to be huge because our other patients with a central venous catheter, the diameter of that catheter is smaller. It's a little bit smaller. It's a bit smaller. You're going to notice it. And when you have a dialysis patient with a catheter that's in their chest, it's going to be big. It's going to be large, and it's going to have two hubs on it. And one's going to be blue and one's going to be red. And so one is for the artery and one is for the vein, usually blue vein, red artery. And so it's just that simple where those alert you to the large bore central catheter with the two hubs on it, blue and red. And you're going to go, that's more so for dialysis, that's specially surgically implanted for dialysis. And that access is usually what's reserved for cardiac arrest. When they're arresting, you can usually go ahead and get permission from your medical director to use that site for administering any medications or drugs. And so the fistulas you want to be mindful of. You don't ever want to do a blood pressure on the same arm as those fistulas. There is so much pressure that's built up to build up that fistula. You do not need to help it by putting a blood pressure cuff on and adding more pressure to that site. So avoid blood pressures on the side where you see the fistula, and just be mindful that it's not a bulging AC, it's not a bulging regular vein, it's under a lot of pressure. So I would opt to go for an IO if you need immediate access rather than accessing that, because you're going to open a whole ball of wax with hemorrhaging, bleeding, other issues, and you'll have to dedicate a whole crew member to occluding that site and stopping that site from bleeding and losing that person to a delegated task that didn't need to be performed. So there. And here's some visual images of those. The first visual is that AV fistula. So that looks like a great vein. And man, sometimes you get patients that just normally have ACs that look like that, but not with your dialysis patients. And so that is to be avoided with IV access there. And then your dialysis catheter, like we talked about, the blue and the red ports. And then a whole nother deal where you're going to have the peritoneal dialysis port that's inserted into the patient's abdomen. And so that is a port where dialysis is performed, and it just sounds so medieval. It's a volume infused solution that helps clean out by kind of an osmotic pull of solution, and it's a pretty intense and labor involved technique where the patient's usually doing this 4 or 5 times a day, inserting the volume, draining the volume, and it becomes kind of a intense procedure that they're doing quite often. But just for our note, if you see that coming out of the patient, it's a dialysis patient. they're probably their electrolytes are probably off. They've probably got some more things going on when they call you for that chest pain. Be mindful. Oh, they have a dialysis peritoneal catheter. There's probably something more going on. But and again, pulling that out, the abdominal wall trauma might occur, and so bulky dressing on that. But don't stop with transport because there's probably something bigger going on than just that tube getting pulled out. And so don't pause, just keep moving forward. So this little slide here with the dialysis patient management is just a little tidbit, just a little toss in there because what happens when you get called to a patient's home and they're having chest pain, they're diaphoretic, they're pale, they probably got peak T waves, and pretty soon they're going to run into some PVCs and probably cardiac arrest, probably because their electrolytes aren't great. But here they are sitting in their recliner, attached with needles in their fistula to their dialysis machine. What do you do? Because you've got this huge machine and this large blood port that in their arm that what's the simplest, fastest thing to do? First, follow the guidelines for your medical director. You want to follow whatever policy or procedure that has been created. And this, again, is to open discussion to your provider. Do we have anything in place? Do we know what to do if we go to a patient's home and they're a dialysis patient? Open that line of discussion. So you'll want to be able to realize and recognize, no, you don't want to take that dialysis machine because it's about the size of a hospital ventilator. It's on a stand and it's definitely bulky and would be highly entertaining to watch you try to get it out of the patient's house. So you want to disconnect. And so there's going to be 2 needles or 2 access lines that are going into that AV fistula. Let's say it's in the patient's arm. Side note, fistulas can be in a patient's leg. That bulky vein can be whatever large artery vein connection that the patient has left. And so usually they try to start in the arms. And if the patient's been on dialysis for years and they're doing well, those sites get old and they keep redoing them. So it could actually be in somebody's leg. But let's say you go to a scene call and the fistula is in the patient's arm and it's accessed and it's got the 2 lines inserted into that fistula and it's hooked up to the machine. First thing, the machine needs to be stopped. You need to have that machine not pulling any more blood or any circulating blood volume going on. So hit stop on the machine. But you might want to just take a quick photo, quick snapshot of the screen face because it's going to have how much volume has been taken out of the patient and how much is to be returned. So you know kind of the hemodynamic status of your patient. And so you'll want to document that so you can share that with the receiving doctor. So stop the machine. And then each line, basically near the patient's arm, is going to have 2 clamps. So there's going to be a total of 4 clamps. Clamp them all 4 clamps, because one of them is going to be a clamp on the side that's going to stay with the machine for each line. So you're going to have 2 clamps that are going to stay with the machine, 2 clamps that are going to come with the patient on their arm. And then there's a hub that you can unscrew the line from the patient to the machine. And so there's 2 hubs, 4 clamps. Clamp all 4, unscrew each hub. Don't take any needles out. Don't remove any lines. Don't waste time. Just secure it, wrap it if you have to, and make sure that arm stays fairly straight because there's probably needles and tubing there. And so just don't dislodge any of that. Because remember, if you dislodge anything from a fistula, you're going to have a ton of bleeding. So do you opt to have a crew member that's just standing there completely holding pressure and hands that could be used for CPR or administering drugs, anything along those lines? Keep all hands on deck for actual stuff that needs to be done and don't create any more problem that you have to. But it could happen. They could get pulled out. That's a lot of blood, a lot of back pressure. You need direct pressure on that side. It needs a heavy dose of direct pressure. And usually the minimal amount of time is 20 minutes to keep that pressure on. Some EMS providers and agencies have dialysis clamps. So you might have those in your facility or agency. So check around. It's actually used for upper extremity fistulas where it's just this looks like a C clamp and you can just put it over the fistula with a bulky dressing and then clamp it down and it applies direct pressure for you. So that's a little side note addition that you can kind of discuss with your medical provider if need be, but if you don't already have those in place. So the key is you need to get the patient unhooked from the dialysis machine. You need to get the patient out of the house and on the way to the facility, especially if they're doing poorly. So, and then just little bonus lines and catheters, just things that hopefully you'll never have to see or experience, because you've got the bolts that are implanted in the skull for any drainage or anything with cranial pressure, and then the ventrosity catheter, that basically the EVD drain, that's very scary to transport, because if you drop that, then all of their cerebral spinal fluid comes out.
Oh, that's it. That's
That's
the
it.
only.
That one's a bad one, and
Gotcha.
so
Good to know.
so usually
Avoid
that's
that one.
a highly trained person that's going to be dealing with that one. Blakemore tubes, we might see those. That's to stop usually esophageal bleeding. One time we had a creative surgeon that the patient had massive bleeding, esophageal varices bleeding, and it would not stop bleeding. So he had to apply some pressure on that tube. And so he hung it with a 1 pound weight on it. So the whole time we were transporting in flight, we had to keep this 1 pound of pressure on this
Oh my
tube.
gosh.
Yeah, so just to make things harder, you never know what you're going to see, but kind of research and go through and look up tubes that you might encounter. Because Blakemore, Google it, just Mr. Google it and check it out, because you might encounter it on a transport one day. Nephrostomy tubes, little tubes that come out of your kidneys that drain urine. You might encounter if somebody's had some kidney surgery or kidney damage, and even transvenous line pacing. If you're transporting somebody that has a transvenous pacer, that goes in the vein and it goes into the heart wall and it rests up against the heart. And so it's basically an internal um, line that paces the heart through a little 9-volt battery operated piece of equipment. So you're just like, go a little 9-volt, because it's keeping that patient's heart beating. But so you just never know what you'll encounter. But Google stuff and look it up and educate yourself. And so tracheostomy tubes, those are always fun to encounter when we have our patients, because I think this is something we actually see quite a bit in the pre-hospital realm, because and if we're transporting patients from nursing home facilities or care facilities, and we see these, and it is absolutely possible for these to get dislodged, and oftentimes the tubes that are put in are for long-term ventilatory status. If somebody um, needs ventilatory assistance and they're on a ventilator, the funny thing is these patients often know how to use their ventilator and know how to manipulate and work everything better than I do. They know how to adjust numbers and dial in everything if there's anything going on. They're pretty well versed in it. But let's say that tube gets dislodged or pulled out. Oftentimes, unless it's a very well established stoma, it needs a dilator to insert the new tube in. So you pulled it out, it's going to be a little bit more difficult than just shoving it back in. It's something that we don't really want to do. So you've pulled out the tube and it comes out with the plastic trach piece, and then you're just like, oh my gosh, I just pulled out their method of breathing. What do we do? It's just that easy. You shove another smaller size ET tube down that hole, inflate the balloon,
And for BLS providers, use a bag valve
use a
mask with a
bag valve.
pediatric mask over the
Boom.
stoma.
Exactly.
Problem solved.
Problem solved. Don't panic. It's just needing a little bit of ventilatory assist and keep it simple. The piece of plastic came out. Just refocus, realign what needs to be done, what interventions need to be done, and work with the patient and help them whatever they need to have interventions performed.
This is just kind of to see what people think, right? So the most common problem with trach tubes is A, is it pneumothorax, B, equipment failure, C, dislodged, displaced, or disconnected, or is it D, obstruction? So if we're encountering problems with this, let's kind of see what people think. Got a couple people who are like, well, the lecture is about dislodging, disconnecting.
Whoops.
Yeah, so hopefully the most common thing isn't pulling it out, but I mean, you never know, right? All right, so that one, 41% dislodged, displaced, or disconnected with 57% of people thinking obstruction, which this one is obstruction. So the good news is
Yeah.
usually it's obstructed. It's not, we're not going there because it's been pulled out, thankfully, because that'd be
Yeah,
terrible.
that would be bad, but it's almost it's almost harder to get an obstruction out than to fix a tube that's been taken out, because if there's no obstruction, you just have to put another tube or another way to help the patient breathe. But obstructions, if they've got mucus or a mucus plug, it is sometimes very hard to get those out. And the suctioning method and being able to time the suction with the patient's breathing and not suctioning for too long, because then they can become hypoxic. Things along those lines, being aware of and being educated about when you're around a trach patient. And so, but yeah, sometimes those obstructions, that's the trickiest part.
So this is just that, I love this, the DOPE acronym, right? Of just your common issues and, kind of how to solve them. You want to talk through, you've already talked about the dislodgement and obstruction, but if you're getting a pneumothorax with a trach tube, you want to talk about how to deal with that. And then of course, equipment failure,
Yeah,
just give a
all
real
of the
quick.
above. And don't so the obstruction, again, the most common, sometimes a little bit of saline, a little bit of moistening in the tube helps loosen it up and thin it up so it can come out with the suction. And just remember, go back to your basics. If you're suctioning somebody, um, you should never suction longer than you can hold your own breath. And so, or what's maybe even half of that, because if you're fairly healthy and have good lung volume, you should try to hold your breath with your patient while you're suctioning, so you know what they might be encountering. And then the pneumothorax, again, you just basically go back to that concept of, now we're dealing with something along a different path, and we're going to be working down that different ventilatory issue complication. And don't get ever hung up on equipment failure. Look at your patient, monitor your patient, check some vitals, communicate with your patient, reassure them, and have that confidence that you can manage and work through whatever equipment failure you've got going on. Again, if their ventilator quits working, bag valve, I mean, just simplify, and communicate with your patient.
Great. So a couple of pending questions that we'll ask you and see what you got. So one of them is, what can be done if a patient starts pulling on a Foley catheter and either they pulled it all the way out or they pull it out just enough that urinary flow stops? Like what's our game plan with that?
And that's a tough one, because especially in pre-hospital, it's difficult. It's usually happens in our older population, because I have had a few younger male population who were mad about having a Foley catheter and told me they were going to rip it out, and I said okay, and then they don't,
You only do it once.
and they
Yeah.
only do it once. But it's um, if possible, there is a little hub, and this is just, again, becoming familiar with the Foley catheter and the tubing. There is a little port that you just hook a syringe up to, and once you push the syringe on it, usually the air is released immediately. It pulls the air from that bulb that kept it in place is released, and then the tube from the Foley catheter will fall basically right out. It'll come right out. Everything is well lubricated, and it can slide out, and then hopefully urinary flow returned and there wasn't too much urethral damage that occurred. But you'll often know too if the urine is bloody when it comes out, and that'll be a good indicator if there was any torn urethra. And if not, then usually the trauma was minimal. So
Perfect.
yeah.
And the second one is, so direct pressure is indicated for a bleeding fistula, right? But if you're not supposed to do blood pressures on that side, should you do a tourniquet to help with the bleeding? Like, does direct pressure on that fistula cause any problems, or like, what's the game plan with that?
It would be direct pressure, because anything that would cause a backflow of pressure is going to be too much. So like blood pressure cuffs, tourniquets, direct pressure is the way to go. That's where dialysis centers come into play, where they've invented the direct pressure clamps. It is the basically the gold standard for stopping bleeding. That I don't even think a tourniquet would even slow it down, because you've created a surgical vessel that has arterial and venous flow to it. It's like this man-made superpower that a tourniquet wouldn't even quell it enough. It's direct pressure. That's the kind of the gold standard with that.
Perfect. Awesome. Well, thanks for that.
Yeah.
A couple of things as we finish up a little bit early so we can all, in our evaluations that CAPSI requires, thanks, Sheri, for a super informative lecture, just a little bit shorter than usual, which is awesome. So a couple things. Number one, if you're an EMS Connect user, give us just a few minutes to get the attendees imported over to the EMS Connect side. Then you can go ahead and take that test. If you are taking that test, a CAPSI survey is required by CAPSI at the start of that test. We've been saying this in our lectures because we get people who complain on the surveys about the survey. We can't control the surveys. That's something that's required by CAPSI. So we understand we do use it. We give feedback to our speakers as well as take information about things you liked, things you didn't like, ideas you have for other topics. So keep those coming. But that CAPSI survey does pop up before your post test. We can't do anything about it. So quite frankly, I guess deal with it. There is the post test over there, the BLS test for our BLS providers and the advanced test for our advanced providers. Have that quick fact sheet out. That is going to help you out through some of these questions, as well as just kind of looking at some of your notes and remembering some of the things that we talked about. So that test will be uploaded or be open for you shortly. The thing mostly we'll wait for is our $50 Amazon gift card. Our winner tonight is EJ Vargas. So congrats on winning that gift card. We'll throw it up on Facebook. We'll reach out to you via email with whatever email you registered with this webinar for, and we will get that out to you as quick as we possibly can. As always, any questions, comments, concerns, topic ideas, anything along those lines, info@emsconnect.org. I know we're all getting close to research time, so if you have any issues with that, please let us know, whether it's Washington State or other states, or especially on the national side, so we'll help you out. And then that, thank you, Sheri, for joining us for a live lecture. We look forward to having you back. I'm sure everyone will be excited to hopefully encounter you in the field with how much knowledge you bring. So thanks very much.
Thank you.
Everyone have a good night. We'll be on for a few more minutes if you got any more questions that pop up. But other than that, have a great night. We appreciate you all tuning in, and we'll see you guys next month.